Good afternoon, everybody, and welcome to this afternoon's event, which is one of a number that make up this year's Carers Parliament. I'm Simon Hodgson, I'm the Director of Carers Scotland, and we're one of the national core care organisations that helps put together the Carers Parliament every year. One of the few benefits of the way we've all had to adjust our lives over this year has been the growth of the way we use video conferencing. One of the few benefits, I have to say. Most of you wouldn't have been willing or able even to travel from every part of Scotland to attend a 1-hour meeting. Yet here we are this afternoon with, as of about 5 minutes ago, 211 carers from right across Scotland gathered together. Just before I introduce Professor Jason Leitch, there are a couple of housekeeping things I need to let you know. First of all, the event is being subtitled, and if you want to turn this feature on, click on the CC at the bottom of the video. If you have any technical issues, then try and, first of all, refresh your browser or close the window and use the link we sent you to rejoin. That's the classic IT solution to everything, is to turn it off and turn it back on again. If this doesn't work, then email our hosts at hello@fundraisingeverywhere.com. Again, this information was included in the delegate pack that we sent out to you. Could I also draw your attention to the chat box on the right of your screen? If you're going to use this, which we really hope you will, please introduce yourself and say a little bit about where you're from and add any other comments that you want to make about the event. But what we're particularly keen on is for you to pose questions that you would like me to ask Professor Leitch this afternoon. The format for the event is that Professor Leitch will give a short introductory presentation and we'll then take questions for the rest of the time. So we've got quite a long time, I think, to be asking questions. Some of you submitted questions when registering for the event, and I've got those with me, so I can start the ball rolling and get once the presentation's been completed. But if you put questions in, we'll try and get through as many of those as possible. Okay, I'm just being told through my chat box that Jason hasn't quite arrived yet. I think he's probably having a really busy day. So I'm just going to hang fire a little bit before I do his introduction. What I would say is that this is, I think, the fifth of six events that have happened over the last yesterday and today, all of which are giving carers an opportunity to formulate questions that they would like to ask key decision makers. And not everybody that's registered to attend today is yet registered for the Carers Parliament, which is taking place next Wednesday. So if you haven't done that, then once this is finished, then there's still an opportunity to go to the Carers Scotland website and just register for the event. And you can do that right up to the morning next week. Yes. Since Jason's not here, I suppose I could just say a few things about him that I picked up while I was doing my preparation. It looks like he might have gone to the wrong room, and he'll be with us anytime. He can't hear me probably at the moment since he's in a different room. So I would just say that one of the things I discovered was that he had gone to Airdrie Academy, and one of my best friends taught there for many years. He's retired now. And I checked with him, and it turned out that he started teaching just at the time that Jason was leaving. But his wife was teaching at the school at the same time, so we did a little bit of trawling around to see if we could find any interesting gossip about him. The only thing that we came up with was that he was a regular in the school drama productions, but didn't get any further on whether he was any good at that. For some reason, he's managed to find himself in a different room on the back of this platform. And he's just being asked to move into this room so I can introduce him properly. I didn't have any jokes prepared for doing this section, I'm afraid. Oh, all sorts of people are now trying to get hold of him. Right, now looks like he's with us, so I'm now going to do my introductions to him. So it does give me great pleasure to introduce Professor Jason Leitch, Scotland's Clinical Director. I'm sure when he took this job, he never expected to become quite so famous. It's almost impossible nowadays to turn on the TV, radio, or look at social media without him being present. Probably one of the busiest people in Scotland. And I suspect he's only available today because as we do this meeting, the First Minister is doing her daily briefing in Parliament, so he doesn't get to stand next to her to answer all the difficult questions from journalists. So Jason, welcome, and over to you.
Simon, thank you so much. I'm sorry for the slight technical glitch. I think we also may have another one because I'm not sure you've got... I was going to just do a few slides. I'm sending them from my other computer to this computer, so we'll get them eventually. But if somebody has them and is in control, they could put them up. If not, they will perhaps arrive on this machine shortly. Let me just forward them to this machine. I can talk without them. Forgive me. So thank you for having me, everybody. I'm Jason Leitch, the National Clinical Director of the Scottish Government, and it's a great pleasure to join you. I'm hoping to spend most of our time in question and answer, and I'm very happy. You can't be the toughest crowd I've faced during these 9 months. Surely you're not the toughest crowd. But let me start with something that I hope you don't think is patronising, but has the potential to patronise, and that's a big thank you for everything you've done. Now, you were doing a lot before the pandemic, and you were crucial to the society, to the health and social care system before this, but you're even more important now. And I can't imagine that your lives haven't been turned on their head with a lot of challenges, but also I hope a lot of joy, a lot of volunteering, a lot of kindness, a lot of community spirit that I hope you'll agree has been crucial in this fight against this horrid virus. So that's my slides just arriving into the inbox that I require. So let me just bring them up. So I was going to do that anyway, but this pause allows me to do it all the more importantly. And I also am conscious, although I don't walk in your shoes, I'm conscious of the challenge this has been. And in a, let's call it a particular niche, a particular sector of society, then it's been more difficult for some than for others. That's not to feel sorry for you, and I know that's not what you seek. But the reality is that a caring environment is more difficult during the pandemic than it was before, and it was often difficult enough before. Somebody estimated that carers in Scotland account for something like £5 billion worth of health and social care service, or somewhere in that region. And each of you is very, very much responsible for that. And we literally couldn't do it without you. So I'm going to just share what I hope will be my screen, but it's now asking me to do an additional step. Sorry, folks. The story I'm going to tell you, I can start by telling you without the visual, and that is, no, it's not going to let me do it without closing down and coming back in again, so let's not bother. So the story I want to tell you is of Tedros. Tedros is the Director General of the WHO. He's a former Ethiopian health minister. He's a very interesting man. And when the music stopped, he was sitting in the seat, the Director General of the WHO seat. And hugely challenging, hugely difficult, but the right guy for the job. Some of us know him, and he is a global public health leader and the right guy for the task. One of the things the WHO can do is they can declare a global public health emergency. Denise, if you can show the slides, I've just seen you in the chat. That would be great. I'm very happy to tell you when to move them on, but don't worry, I can do it without them. But if you show the first slide of Tedros, there we go. Good old Denise. Why didn't I know that from the beginning? So if you click to the next one, Denise, you'll see a table of numbers. So let's go to 2014. A global public health emergency is declared in West Africa, and the WHO call it a global public health emergency. They declare that the world should pay attention. So all the clinical directors in the world, me and the Ethiopian and the Somalian and the Danish, we tell our health ministers, here's the thing, there's a big infection and it's going to kill people and it's going to come to Scotland. We need to get the pandemic plan off the shelf. And one Scottish person caught the virus. She was called Pauline Cafferty. Many people know her. She was on the front page of paper. She survived. We flew her to the Royal London in a Hercules jumbo, and she was treated in one of 2 isolation chambers, and she did really well. She was the only Scot to get the infection. We had no spread in the country whatsoever. But the disease is horrible. I mean, infected 30,000 people, killed nearly 11,500. It's a horrible disease. So then fast forward 5 years later, we're at the end of 2019, Hogmanay, and the WHO declare a global public health emergency. And we do the same again. It's not a day I'll forget in a hurry. All the public health leaders in the country, we run around trying to find out what this virus is called. It didn't have a name. And we now call it SARS-CoV-19. It is the virus that gives you COVID. And 2 days ago, it had infected 51,000 people and killed 1.3 million. Yesterday, 12,500 people died of this disease, and 350,000 caught it just in Europe. In Scotland, we're running at around 1,200 cases a day and somewhere between 40 and 60 deaths every day. We now know a lot more about it, but we don't know enough about it. We don't know exactly who it attacks and who it kills. We know a bit more about its transmission, but not enough. And we learn all the time. It is a novel infectious agent. We have not encountered it before. So if you think this is normal, you've misunderstood. And I don't think anybody in this room thinks this is entirely normal. If you just go to the next slide for me. So what do you do when faced with a novel infectious agent that kills particularly the elderly, but also some other high-risk groups? The single biggest risk for this disease is age by a mile. And then some other chronic conditions, heart failure, diabetes, respiratory disease, but principally age. So this is the Grassmarket, a quarter mile from Edinburgh Castle, just down the hill. Some of you will know it. It's a social centre of a European capital city. And if you click to the next slide, you'll see what it looked like the first week in April. So this is the treatment. This is what we did. 180 odd countries in the world put their citizens in their houses. We told them to stay at home except for supplies, caring, and exercise. We closed our schools for the first time in the modern era. We closed our colleges and universities. We shut our businesses. We sent the civil service home. It is completely unprecedented. And we did it, next slide, to buy ourselves time. And that time was for science, to try and catch up, to try and help us out of this. And you can see even now, 11 months later, we're still relying on that time to allow science. And some great news this week, which we can talk about maybe in the questioning, about vaccines and testing, faster testing, etc. The next slide begins to make this problem even bigger, though. So this is what we did. We did the hammer. And the hammer is the green line. About 8 weeks of lockdown gets you to almost single-digit infections. 14s, 17s, a couple of days of single numbers. If you do nothing, you get the black line and you get exponential growth, more death, Northern Italy, intensive care overwhelmed, hospitals struggling. If you just mitigate, you get the red line. That's what a lot of people think we should be doing. I get a lot of criticism for the hammer. And the hammer is lockdown. It's everybody at home. And now we're in the dance. We're in that much more difficult period. The hammer was easy from a public health perspective, not easy from a society perspective. But the dance is much more difficult from a public health perspective. Balancing along a tightrope, if you'll forgive the mixed metaphors, of all of the harms. And let's talk a little bit about what those harms look like in a moment. Next slide. And now the dance looks a little like this. You try and control the outbreaks. This is Aberdeen City, a hospitality-linked outbreak. The biggest chicken processing plant in Scotland in Cooper Angus, 1,200 people, 19 languages, houses of multiple occupancy, a very well-controlled outbreak by the public health teams and the local authority in Perth and Kinross. A call centre in Lanarkshire, our first big workplace outbreak. And now we're in the central belt outbreak of community transmission. And the First Minister is, of course, as you just said, on her feet just now announcing what's going to happen to the country in the next few days. And that is one of the reasons I'm able to speak to you, because she doesn't need to speak to me when she's actually speaking. Unfortunately, this is not just a healthcare problem. So if you go to the next slide, if the exam question from the First Minister to the advisors was, how do I reduce harm from coronavirus? That's pretty straightforward. Let's go back to the 23rd of March, shut the country down and wait for a vaccine. Unfortunately, you simply can't do that. The cost is too high. The harm is too great. So the exam question is, how do you reduce death from coronavirus, reduce non-virus harms to the population, and keep health and social care staff safe and supported? So that's a completely different set of circumstances. If you go to the next slide, this is the lens through which we examine that question. And I think it's quite a helpful way of thinking about it. And then we'll move to questions. So there are 4 harms from COVID. There's the direct COVID harm, death, misery, long-term disease from the virus, from the actual infection. That's harm number 1. Harm number 2 is how you are affected inside the health and social care service. So increased waiting times, it may be elongating mental health times, it affects on health service that aren't necessarily COVID, but by doing COVID, you've had to restrict other things. So theatres are closed because they've been turned into intensive care units. GPs can't do as many face-to-face consultations. Dentists can't do as many cases. The social harms, so loneliness, the closure of schools and the lack of free school meals for some of our kids. 110,000 children in Scotland get free school meals at the weekend. And we closed schools for 5 months. We replaced them with children's hubs and other things. And caring is inside that social harm, of course it is. And then the direct economic harm, the loss of jobs, the loss of businesses, the loss of growth in our country. So let's quickly look at some data around each of these harms. The next slide is very clearly the first harm. So this is deaths from COVID, registered on death certificates by doctors, either as a suggested or an actual cause of death. And you can see we're now clearly in that second wave. We're not at the same scale as we are in wave 1, but you can see, and that's partly because care has got a bit better, and it's partly because we're at lower numbers, and it's partly because the elderly are protecting themselves without us telling them to quite as much. But that's harm number 1, very direct harm from virus. Harm number 2 in the next slide is waiting times. So this is cancelled operations. So this is the number of planned procedures we did in April, May, June, July. You see the graph, and you see how it comes back the way it does. And the emergency admissions, you see also the way that works. And the next slide is societal and economic harm. So the best protection against COVID is wealth. You are much more likely to survive it. You're much less likely to get it if you are wealthy. If you have a house in which you can self-isolate, if you have a job that will continue to pay you, if you have a family who can support you, and you can get your groceries delivered or your Amazon parcels delivered. If you are a single parent in a high-rise with 3 kids at school, no supportive family, and no money to get your Waitrose delivered, I'm afraid you are much more at risk of this disease. That's true of most diseases, and this infectious disease is no different. It exposes the deep-seated inequalities in our society and every other society that is facing this disease. And you can see unemployed people, 25.85% say they are not coping well with the stress of the pandemic compared to those who are in employment. You get the idea. Next slide. So let's finish on some hope, though, and some good news. So you have followed, I imagine, the news this week. 2 big targets met in the 2 of the first vaccines. They're not done. We don't have all the safety data. We don't know for sure when they will come, but they are doing well. 90% and 95% success in the first phase 3 trials is very, very good for vaccines. That's not true of many other vaccines. The flu vaccine, for instance, is about 60% successful. So a 90% successful vaccine would be an astonishing result for us. And we've got, as you can see from this little graph, we've got about 200 nearly vaccines in train, and 3 or 4 of them now in phase 3 trials. Phase 3 trials are thousands of people. They are broad, all ages, lots of different conditions, so that we can check safety and efficacy in those broad ranges. And although we will get some vaccine before Christmas, we won't get big numbers, and the logistics of the delivery will be very, very difficult. But we will get big numbers in the first and second quarter of 2021, when we will vaccinate the population. But remember, we have to vaccinate the world, not just Scotland. You can't fix this problem by vaccinating Scotland. You have to also vaccinate Norway and Nigeria. So the WHO are holding the ball for that, holding the money in order for us to be able to do that. And I hope that gives you some hope. The next slide is meant to be hopeful, but realistic. I'm afraid this is not going to be over in the next 3 months. We are going to live with this for some time to come. And then we will live with it in an endemic way, like we do with flu or the common cold or other respiratory viruses. And we're going to have to learn how that works and what protection we can take to do that. But the vaccine is going to help us as long as it stays both safe and effective against this particular virus. We need to pray and hope that it doesn't mutate into something more vicious. And that's why we got a bit excited about the mink story in Denmark, you may have noticed over the last few days. But so far, it appears to be stable enough for us to vaccinate against it. So, not out of the woods, but hope in the last couple of weeks. But the numbers in Scotland are still too high. And the First Minister will be announcing, in fact, she will have done in the last 3 minutes, that bits of the country are moving to level 4 in order to get those numbers down further, particularly in time for Christmas. So, thank you very much. I'm happy to take any questions you've got, and thank you, Denise, so much for finding those slides so quickly.
Thanks very much, Jason. I'm going to start the ball rolling with some questions that we got sent in when people registered for the event, and in the meantime, people are transferring questions across from the audience as well. So I'll get to those once we've gone through some of these, if that's okay with you.
Of course.
So these are all from carers that are attending today, so I'm not going to make any judgment on them. I'm just going to ask you the questions. So the first one says, if we enter a further period where people with certain conditions are asked to shield, will there be more recognition that there are others with disabilities out with these categories who are equally vulnerable to the risks of COVID? And will the guidance include measures to assist them and their carers while self-isolating?
Well, firstly, we're not going to tell anybody to shield. So shielding is still a category. So we're going to talk about those who were formerly shielding. But we're much more likely to talk about those at risk. And that's a continuum. That's not a light switch. It's not no risk and risk. It's a continuum of risk. And of course, those in the shielded group are in that risk group in the main. But we now know a lot more about this disease than we did in March. So we know the risk groups are different. We know, for example, that you might put transplant people somewhere different. You might put diabetes in there where you wouldn't have before. You might put obesity in there and you hadn't before, because we now know the kind of people who get this disease severely. So you still hear us talk about the shielded group, but really what we mean is the people at higher risk. And that's a thing you can assess yourself. There's some risk assessment stuff online. You can do your own risk assessments. Your employers can now do risk assessments. And the fundamental rule will be, if you are in a high risk group, be even more careful than the rest of the population. In level 4, which will now be some of the central belt, we're suggesting that if possible, you should work from home. But that's true of the whole population. What we're saying is you should have a very serious conversation with your employer. And if they can give you something to do that is at home, if you're a civil servant, if you're working for a third sector organisation, then they should facilitate that for you. If you're a teacher or a nursery educator, you can't do that from home. So there has to then be a conversation between you and the employer that says, how can we make this as safe as possible? How can we mitigate the risk? Because these institutions are going to stay open. So, and that's the right thing to do. We think schools are important enough for them to stay open even in level 4. The one nuance of that is we're suggesting that children who were formerly shielding, and it's a small group, in consultation with their clinical teams, probably shouldn't go to school if they're in level 4. They should have special facilities created. They should have blended learning. They should be at home. But that's a pretty small group and not as big a group as we had in March.
Okay, that's great. Okay, the next question, you've sort of mentioned it a bit. The requirements to work from home where possible to restrict visits between houses and to socially distance can have a massive impact upon carers, particularly given the restricted access to health and social care support. What recognition is there of the need to prioritise support to carers over the period ahead?
So on a practical level, you can be, well, on an intellectual level, you can be absolutely certain that carers are mentioned in pretty much every support conversation inside the government. I mean, they're never missed off that bullet point list. Now that's all very well. That's what warm words. How does that help me? So you can be certain that those who advocate for you and those who understand the health and care system talk about carers in the same breath as they talk about patients and families, and they are always in that conversation. Now, the practical support, both financial, resourcing, organisational, third sector, that's a slightly different question, and I hope that we have prioritised that appropriately. I know that won't be a universal view because there is a limited pot of people and resource and money, and organisations like Carers Scotland advocate for that very, very well, and I don't think we could do it without the third sector. I could list to you the millions and the pound signs and the what's gone to what pot and what that doesn't really help you if you're the carer in Elgin who's either receiving support or not receiving support. Knowing there's 10 million quid in a pot somewhere doesn't really help you very much. But I can absolutely promise you that carers are inside that decision making and prioritised inside the cabinet conversations, inside the levels conversations, and you have very strong advocates inside the cabinet. From your cabinet secretaries, the appropriate cabinet secretaries, and from me, if you'll forgive me for saying so.
That's great, thank you. This one's quite topical, actually. It's sort of in the media today, but it was tabled in the run-up to this, so I'm going to ask it anyway. You may not be able to give a definitive answer. Care home staff are getting tested, but staff providing care at home are not. Carers continue to be worried that the people coming into their houses might bring in COVID with them. When will care workers coming into homes be tested?
It's a good question. I can't give you a definitive answer. I can tell you they're on the list in the testing strategy, and we will get to them when capacity and testing technology allow us to do that. We think they are a very important group. Let's be clear though what testing can do and what it can't do. So it's important, but it's not the only thing that's important. It can't find the virus if you're incubating. It can only find the virus if you're shedding. So it misses a lot of people. The new technologies, what you've heard, the LAMP technologies and the LAMPAR technologies, they are not as good as the swab and the PCR testing that we've been doing now for 9 months. So they only find about 60% of people who are even shedding the virus. So it is not a panacea. It doesn't solve all the problems. It will still be important to distance, to hand wash, to do what you absolutely can, as much as you can around those mitigations. But testing will be one of the ways that we make the carer and the cared for safer. I have no question. The principal way, though, to make that safe is to reduce transmission in the whole of the community. So carers are not as worried in Orkney as they are in North Lanarkshire because there's not so much virus in Orkney. And that's because the virus has been suppressed to such a low level. So the most important thing remains reducing the prevalence of the virus. I also agree testing and everything else is absolutely crucial. But the most important thing is to get the community prevalence down to make everybody safe, including carers and those they care for.
Okay, thank you very much. This one's from a carer who's looking after a 92-year-old mother and has done for the last 4 years, and she's struggling a little bit with employment, and she's worried about her finances. And she's also terrified about going back to work where she would be exposed to a large volume of people, sort of bringing the virus back to her mum. And she's asked a number of questions, so I'll just give you all three of them because you can wrap them together. One, are there any particular jobs that you think are safe for people also caring for people at risk? How safe is it to get social care support provided by my local authority to enable me to work? And this one is a slightly more tricky one. It's just why during the pandemic can't carers be paid a wage rather than have to bring in outside carers to provide that support in the house?
Yeah, so the third one's above my pay grade, I'm afraid. That's a.
I thought we'd just drop it in there so you knew about it.
It's a good question, though, isn't it? It's a good question when I say carers provide £5 billion worth of support, but
that's an underestimate, I think.
Yeah, probably. Yeah, so that's a policy level decision about what you do to value carers and their contribution. So warm words is one thing, but actual financial support is something else entirely. I have a lot of sympathy with that position. You'd have to decide with the restricted budget that each country has, whether you're in Norway or Scotland, what would you use to pay that money? So that's the reality of what the decision makers face every day. So what are you going to not do in order to do that? I'm not trying to put it down the priority list, but that's the kind of decision you'd have to take. Yes, it is safe to receive social care in your house. It is absolutely safe. It's not 100% safe. It can never be. It wasn't before the pandemic, and it can't be during the pandemic. But the social care teams around the country have played an absolute blinder in terms of training and PPE and support and everything else they've had to do. And they've had to change the way they do it, the long hours they've had to work, the nature of what they do has been transformed. So yes, it is safe to receive social care from the local authority, or as safe as it can be. It is not risk-free, but no path here is risk-free. And the jobs question is really good, isn't it? I feel I can almost hear the angst to try and look after mum and at the same time have purpose and contribute and also want to earn in order to be able to look after mum more. I think the obvious answer is things that would keep you at home if you possibly could. And lots of employers are now finding working from home as productive or even more productive than people going into offices as much as they did with public transport and everything else. And I would hope that Carers Scotland and other carer organisations would be able to help you with some of that, direct you in the right direction. Third sector organisations are usually both very good at employing individuals like that, but also very good at signposting to opportunities like that.
Okay, thanks. Can I just, I've had a question come through about something you said earlier about young people at risk being asked to shield in level 4 areas, which is, what about the siblings of children who were formerly shielding? Should they also not go to school? No,
they should go to school. I mean, it's the same, it's risk. I mean, there is no risk-free path here. And if I had a kid who had been shielding, what I would do is I would speak to it's a small group and they're usually well known to the health system. So what I would do is I would have a conversation with my care team before making any big decisions or radical decisions. And I would then also speak to the educational establishment, the school, the nursery, whatever it is. And then I would make a rounded decision on behalf of my family about what that should be. It's not forever, but we know how important school is to every kid, whether they were shielding or not shielding. It teaches them physical well-being, mental well-being, teaches them education, but it also teaches them teamworking and resilience and how to cope in a crowd, all of those other things. And we don't want that to go away. But it may be that for a little while, we ask them to stay at home to be a little bit more protected from this particular disease. It's very unusual to get seriously ill from this disease if you're a kid, even if you have pre-existing conditions. We've had no deaths in Scotland under 19, I think. There have been a couple of younger deaths in England, a bigger population, but it's very, very unusual to die of this disease if you're young. Not impossible, but unusual.
Okay, thank you for that. Next question is about day services. It says, why are some day services and break services opening and others are not? And how do I know if the services in my area are safe? Should I be worried about sending my daughter to a usual service when it eventually reopens because we are in a tier 3 area, possibly a tier 4 by now?
Yeah, so that's good question. So it lets me talk about the national versus the local guidance, and this is a big challenge around. We're a big country, and Stornoway looks different from Musselburgh. So what we do nationally is give the best advice we can. So that's the tier system. It says this is what unregulated youth work can do. This is what the oil and gas sector can do. This is where you can have a casino open or not. So we can't do individual local decision making. It would be inappropriate. So if you are in Elgin, how you interpret that guidance is, of course, a matter for Elgin, particularly if you're a small third sector organisation that provides maybe addiction services or carer services. And you're going to have to make some choices around there about safety, about the nature of your workforce, the nature of your environment. So have you got a big enough space for people to distance in? Have you got? So I was in a conversation the other day about Alcoholics Anonymous and them restarting, and some of them have never stopped, and some have been cancelled and stopped for 9 months. And the difference is often the workforce, the resources available, the size of the church hall or the community hall in which they're happening. So some of that decision is rightly at a local level, and I can't force every single third sector organisation to open. We've given good guidance about how to do that safely, about sanitizer, about distancing, about checking the risk of the individuals who come to the event. And I think you can be pretty confident that the third sector organisations are taking that very seriously. Both the blanket ones like the Alliance, who look after a lot of them, Carers Scotland, others, and then the individual little groups that might meet in a house or in a home or in a community centre. So once they open, I would think they're safe. They're safe to open. And if they're closed, I'm afraid you're just going to have to be a little more patient.
Right, okay. There was a very similar question that followed on from that, so I won't ask you that since you've given such a comprehensive answer there. The next question is a sort of practical one, which you might be able to answer. With cases rising, will PPE still be available to carers when they need it? And will it also be available for PAs that we employ through direct payments?
The answer to that fundamentally is yes, although I'm reluctant to guarantee or promise. I realise there are some complexities in there about supply chains and who buys it and where, but there is enough PPE in the country for sure. So if there are blockages in that process, you should escalate upwards to whoever is in charge of that particular bit of the puzzle. We have warehouses full of this stuff, and I think the supply chains are much better than they were. The tricky bit was not getting it to the country. The tricky bit was what the procurement people call the last mile. So for actually giving it to the person who has to use it. But I think that's got a lot better. It's got a lot better in care homes and care at home. So my my basic answer is yes, that is available and will be available if we get more numbers. Now, I'm hopeful that today's announcements will get us to Christmas with lower numbers, which is why the advice was to be a bit more restrictive now, I'm afraid.
Right, okay. I suppose it doesn't reduce the numbers of people who are caring still. So
it does not, or those who need that care.
Yeah. The next one's sort of again a sort of fairly common one, I suspect. I travel on public transport to care for a friend. Obviously, I'm worried about this, as this is a direct quote. Nicola has said we should avoid public transport if we can. We all know who Nicola is. I don't have a car and I can't afford taxis, so I don't really have a choice. Are the government planning to offer testing to unpaid carers like me who are having to travel every day to provide care? So that's an extension of the home care testing.
Yeah. So non-regulated home carers are not in the testing strategy. We've had to make choices in there about capacity, about who we can reach and what we can do, and what testing does. Remember, you have to do it regularly in order for it to function. I also travel on public transport when I commute to work. It, as far as I can tell, appears to be very safe. The organisations have done a very good job. I happen to cycle to Queen Street. I then get the train to Edinburgh and walk at the other end and do the same in reverse. I have a horrible, ridiculous long commute. And ScotRail have done a really good job. The bus organisations, I've had a number of conversations with them over 9 months. also have done a lot of mitigation. It's not universally, it's not always true every single journey, but it seems to me to be very safe. And if me, take personal responsibility, face coverings, hand sanitizer, careful about surfaces, and only do it when we have to do it. And people have to do it. Of course they do. If people have to care, they are right to use public transport. It's not that public transport per se is suddenly dangerous. It's just it gives us the opportunity to have interaction. There are surfaces, there are opportunities for the virus to spread there. But I use it a few times a week, and I will continue to do so.
Okay, thank you very much. I'm going to join this question up with some that are coming in from the audience today. So the question was, can Jason explain the logic for COVID screening visitors when frontline NHS staff like myself are not tested? I can care for a care home patient in hospital in my PPE, yet this is deemed inadequate in visiting my mum in a care home. We've had a number of questions about care home visiting, not being able to have physical contact, a hug, a touch. So it sort of follows on from that question, I suppose.
Yeah, I think it's probably the most difficult set of decisions we've faced in 9 months, actually. I think the care home visiting and the care home restrictions have probably been the hardest thing we've done, apart from funerals. So I think the hardest piece of advice I had to give was about restricting the numbers at funerals. That felt an impossible set of choices. And I think care homes and the restrictions on visiting, let's remember, this is not abstract. I have family and friends in care homes too. And so do the politicians, the ones in power and the ones in opposition. So these are real decisions and really hard choices, and there is no easy path. We've taken a lot of criticism for outbreaks in care homes, and we've taken a lot of criticism for our response to outbreaks in care homes. And the balance is really, really difficult. It's about risk. It's about making choices to keep the virus out of these institutions where we have in their homes a lot of the high-risk group. And this virus is nasty and cunning, and it jumps very, very easily from person to person and family to family. And you can go from 1 case to 40 cases in a snap of a finger. So that's why we're so cautious. Now, I think we've got the balance a little more right now, but it still feels to me that as though we need to get better. And I completely agree with you. Watching the images of people seeing their parents or grandparents through glass is completely heartbreaking. It's absolutely heartbreaking. And we absolutely want that to come back. We want hugging, we want touching, we want testing and PPE if that makes that more likely. And we have armies of people working on that with the sector to get that back just as quick as we can. But as we do that, just to balance that for a moment, my inbox is then full of new outbreaks in care homes, where despite all of the safety measures, despite all of the visitors, all of the staff being as careful as they can, the virus gets in. And that's not because somebody did something wrong, it's because the virus is the virus.
Okay. Oh, it's not great, is it? I'm going to just go take a question from the floor because it's sort of in a way related and does relate to actually a letter I got this morning from Jean Freeman that was sent out to all health providers. And the question is, my husband has dementia, and in the event that he would require to go into hospital, I'm not allowed to go with him. Surely some consideration should be given to carers so they can accompany their family members to enable them to explain what is wrong and also to provide support. And actually the letter I got from the CABSEC today said that should be allowed to carry on if people have been providing care. They should, for particular cohorts of people. So I just wondered if you could comment on that.
So that's always been an exemption to the visiting rules and the access rules. Now, remember, again, the balance here is we're trying to be careful. We don't want COVID in, and we don't want you to catch it when you go. And we can't tell where it is. It's not neon lit in the ward, the ambulance, or in your house. You might take it with you, and you might take it into a care of the elderly ward with you. So we've got to be cautious. But one of the exemptions to the visiting rules is if you have to provide essential caring duties, if somebody would get distressed without you. So my granny, when she broke her hip many years ago and died at Glasgow Royal Infirmary, I was the one who went in with her drugs and told the doctors and nurses what drugs she was on. If that happened tomorrow, I would expect to do the same. And that should absolutely be part of the equation. Now, you might find it slightly different. And people, remember, on all sides of this pandemic are scared. So the health and social care teams are scared too. They're worried about themselves and their families and their other patients. So don't be surprised if there's some tension sometimes in those conversations that you find a little bit unexpected. So patience, communication, and absolutely you should be able to share those moments with your family. End of life care as well is one of the exemptions to that visiting rule, and you should be able to visit. And if that doesn't happen, you should escalate and make sure it does.
All right, okay, that's really good. We've only got a few minutes left, so I want to just get through a couple of questions that we've tabled in advance, and there probably are more coming through about testing and vaccines. I think you've answered some of the testing questions that were presented earlier about how good they are and how well they work and things. But there's one about vaccines. When a vaccine becomes available, will unpaid carers be prioritised, particularly those who are caring for someone who's been shielding?
So that we have so you've all had to learn. You've learned about SAGE, a lot of you, which is the advisory group for emergencies. Now you're going to have to learn a new committee. So there's a new committee. Well, it's existed for decades. It's called the JCVI, the Joint Committee for Vaccination and Immunisation. It's UK-wide, 4 countries, and it always sits and it decides who gets the flu vaccine, what kind of flu vaccine we'll have, what we'll do about polio, and now it's deciding on the COVID vaccine. It's deciding on the safety of the COVID vaccine, which groups should get it, how we prioritise them. Now, the reality is the logistics will be up to us, of course, but the list of who goes first, who goes second, will be up to the JCVI. And that's the right place to do that. They've got patient and family representatives. They have virologists. They will look at the data to see where it's safe and where it's not. We will absolutely prioritise the over 80s and health and social care workers first, because that's where you get the biggest bang for your buck, basically, because we're trying to protect individuals, but we're also trying at some level to protect the whole population. And until we get population level vaccine numbers, vials, just the amount of vaccine we need, we're not going to be able to do that. And that won't be till the New Year, Easter time. So in the meantime, we have to protect individuals. And that'll mainly be the very, very vulnerable, the elderly and those at high risk. And then inside that will absolutely be household members of those who are in that group. Now, it will depend how many we get. If you get 10,000, then there's very little you can do. If you get 100,000, now you can begin to do something a wee bit different. But you've got 160,000 health and social health, just NHS employees, not all front-facing, not all patient-facing, but there's big numbers quite quickly. And then what do? Do you do the paramedics? Do you do the police? So there's really tricky choices in there, and carers will absolutely be in that mix when that vaccine comes along. But I'm excited about the vaccine, and it's really made me smile this week, but it is not the solution this side of Christmas. It's the solution this side of the summer.
Yeah, no, I think that's fine. But I suppose if you're looking after somebody who's at 85 at home as opposed to them being in a care home, it would seem to make sense, since you're spending all your time with them, that you should be protected the same way that workers in a care home would be, for example.
Yep.
So it just comes down to the maths, but also just making sure they're in the plan at the start rather than being tagged on at the end. That would be, I think, appreciated by carers.
Yep.
Right, I'm going to go take another one from the floor, which is about respite. Carers in Scotland who rely on day service and respite are at breaking point or past it says, and are wondering when respite, other than emergency respite and day services for cared for people, can realistically resume. I know we've had a little bit of conversation about this, but it is a really big concern. It comes up all the time in our research and things. So
it is. I get a lot of questions about it as well, and it's also one of the most difficult things to get back for obvious reasons. It is effectively creating new households with new sets of people, and you can see, knowing what you know about this virus, why that worries everybody, including the respite providers, including those who run Lookie House and run all the other examples of that kind of respite around the country. Hospices have struggled with this. They've moved a lot of their care online, a lot of it virtual. So it's a tricky one because of the risk involved. And the fundamental, and I know this is a bit of a cop-out, the fundamental is get the prevalence down, more can open. So if the prevalence comes down in an area, then you're much more likely to be able to do some of these things that are closed because of the high-risk nature of them. So again, much more likely today in Kirkwall than it is in Airdrie. But with time, as we get that prevalence down, then I'm hopeful that that will return. But the mixing of households is the big challenge there.
Right, okay. You mentioned this before, partly in terms of the shielding discussion we were having, but there's a question here about, will the Scottish Government give specific guidance and regulations to workplaces around carers going to workplaces if work can be done remotely? So instead of just saying we should ask our employers, is there any thought that the government might be much stricter about it, either with guidance or regulations?
So we've given fairly strong guidance about you should work from home if you can. Employers should be sympathetic to that. You shouldn't be penalised, etc., etc. So at either extreme, that works pretty well. So I'm a civil servant. I and my colleagues, shielding or not shielding, pretty much all of the civil service is working from home. Some of us have to go in and do live TV, but when we go in, there's very few of us. There's the First Minister and about half a dozen advisors, and we go down, we do a TV broadcast, and then we go back to our offices. So the civil service is one extreme. At the other extreme, if you're a paramedic, you can't do that from home. So there's no controversy there. You've got to go to work. And if you're shielding, you have a conversation with your workplace and try and make it as safe as you can. So at either extreme, the conversations are relatively straightforward. The difficulty is in the middle. The difficulty is in some that, well, could you be the person who does the blended learning for the history class, or do we have to have you in the school? Is there a way that school administrator could do some of that work from home, maybe half the week, and then come in the up? So they're the more tricky ones. And you can't write government guidance for each of those single eventualities. You have to allow the employer and the employee and the unions to work out what that should look like. And we think that's the best place for that to happen. But people at high risk should be given the opportunity to work from home if they possibly can.
Okay, that's great. Quick supplementary on the hospital discussion we had earlier about accompanying somebody who's being taken in, is about carers being able to go with somebody to an outpatient appointment. So it's not necessarily somebody being taken into the hospital, but just going to attend. Feels there needs to be a clearer guidance so people are not at the whim of face-to-face decisions on the day.
Yeah, so again, I think that's allowed, although you remember, this is all about risk. So my father needs a cataract, which has been cancelled because of COVID, but he's had a couple of appointments during that time. He's relatively fit, but he needs a cataract. So his sight, he's struggling with his sight. He's 79. And conventionally, my sister would take him, and she would take him in, and she would be with him in the waiting room, and she would wait with him and all of that. But the appointments he's had during this process, my advice to them, to my own family, was that she shouldn't do that. He should do that by himself. And that is not risk-free, because he's more at risk just from having to go by himself. But I think it's the right thing to do in terms of COVID. So that's tricky. If he had dementia and couldn't find his own way, then my sister should go with him. Of course she should. But we've had to reduce the level. We've had to lower the bar, unfortunately. And that's really hard. Hard for my family, hard for yours. So I understand the difficulty with that, but we're living with a novel infectious agent that kills the elderly. So we have to be really, really careful. And the last thing you want to do is to somehow increase the opportunity for it to transmit. So we each have a responsibility for that within reason. I'm not suggesting you should drop off somebody at the front door of a hospital who then would be so scared or wouldn't be able to then go to their own outpatient clinic. Of course not.
Right, okay, that's great. I'm going to try and get through a couple more just before we get to the end of this, Jason, if you can. We had one that was tabled by email earlier this morning when somebody registered, and it's about people who are living in supported accommodation. So it says Public Health Scotland have said they should be treated like the rest of the population, that they have their own front door, but managers of these facilities are refusing to accept this guidance. When Scotland went back into restrictions in September, they still have not begun to allow visitors to the buildings or into residents' homes. Many of the people have not had a visit indoors from a friend or relative since mid-March and are prevented even from going to see their loved ones at weekends. This is more restrictive than care homes.
Yeah, so I don't know the detail. You'd need to send it to me, and we could have a look at it. I've got pals and family and friends in assisted accommodation, sheltered, what we used to call sheltered housing. Some of that has gone very well. I've had some really good experiences of people, of the community spirit, of people getting together, of people visiting, and others. I've also heard stories that they felt very restricted, felt a bit trapped, haven't had quite so much visiting or human contact as they would perhaps like. It will depend, of course, on the location and the kind of design of the premises, where the doors are, if they're outdoors or indoors, or whether everybody's going to meet in a communal area indoors or outdoors. But they should be like your own home, because they of course are your own home, and you should be able to do that. Now, we've all been under the restriction of not being able to have people in our houses, whether we live in sheltered housing or in our own houses that we've always lived in. So we're all under that horrible restriction, and it's a really severe restriction, particularly for those who don't have family or aren't out at work or don't have purpose like this all day on Zoom or elsewhere, or don't have a spouse or a kid that they're living with. So I understand the restriction is horrible, but it should be the same for those sheltered accommodations as it should be for the rest of us.
Yeah, I suppose the question, if you're a caring is one of the reasons you are allowed to visit people's homes, isn't it? So I suppose
it absolutely is.
Okay, we're sort of getting towards the end now, so I'm going to wrap together two questions. One that was sent in advance, but it's linked into something that people have raised in the audience as well. So the specific question we got earlier was, do you have any particular suggestions and advice for support with COVID for people with dementia or Alzheimer's, in particular people living alone? Could there be specific information on wearing masks correctly and at appropriate times, and remembering and implementing correct hand washing proceedings? And similarly, the question that was from the floor was the public message reinforcing the need to wear masks over the mouth and nose, so many people not wearing correctly. So it's a sort of question: how do you try and support people with dementia and Alzheimer's to do that correctly?
Yeah, it's tricky, isn't it? So we've followed that old communication maxim of repeat, and then repeat again. Just keep sending the same message out again and again by example. Now, the government can do some of that. The government are not fully trusted, amazingly. I mean, who knew? And the clinical teachers, the clinical voices are a little more trusted than the politics. But we need everybody to help us with that, both the individuals who are in this room, the third sector organisations, the health and social care systems, everybody to help us with that messaging. There are a lot of very good elderly care third sector organisations, Age Scotland and dementia friendly organisations who do help with a lot of that and trying to do it. Remember, face coverings is just one element of the safety regime here. They're not magic. They don't suddenly mean you don't have to distance or you don't have to wash your hands. They're just one additional layer of protection. And we should absolutely do our best to have them and use them. But nor should we force people who are distressed by them into wearing them. We should be sensitive and kind. And I think the pandemic has shown us at our best in terms of kindness, but also sometimes maybe a little bit tense and unkind.
Right, that's absolutely fantastic, Jason. We've got one or two questions we haven't been able to answer, so I was wondering if we could potentially send them on to you after this, just to get a reply. Ones that have been tabled from the floor, but since we've reached the end of the session that we're meant to. I'd just like to thank everybody who's attended today and contributed to the event. We've had some really good, interesting questions being tabled. We've also recorded this, so apart from my early stumbling over the gap at the start.
My fault, Simon. No.
Yeah. But not to worry. But it will be recorded. And we'll make it available in the next few days. Not quite sure how it's going to be made available. We will do that. We'll let people know so they can tell people that weren't able to attend, rather than just watch it all again. Obviously, I've already mentioned to people the main event takes place next week on Wednesday, the Carers Parliament. And if you haven't registered, there's still time to do that. And finally, can I just say a huge thank you to you, Jason, for taking time to attend today. I know everybody will have learned something today they didn't know at the start, and I know how busy your diary is. So thank you very much indeed.
Thank you so much for having me. It was a great pleasure. Maybe we can do it again sometime in the future.
Okay, we'll look forward. We'll try and arrange that. Thank you.